Welcome. I'm Dick Deming, Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Rosalie and Sherry Exline Ziegler Fund. Tonight, we're going to be talking about palliative care, and I'm welcoming my two guests, Allison Roth and Rebekah Rogers. Welcome.
Thank you.
So Allison and Rebekah are both nurse practitioners. So we'll learn a little bit about what is a nurse practitioner. And they both are nurse practitioners at our palliative care center at MercyOne Cancer Center, and are colleagues of mine. And it's just great to have you here.
Thank you. We're very happy to be here.
So tell us a little bit about you. Where did you grow up, and what made you decide to go into nursing? And then we'll talk a bit about how do you go from being a nurse to a nurse practitioner. So Allison, where are you from?
So I'm originally from Nevada, here in Iowa. Grown, raised farm girl. And my mom was actually a nurse. And so kind of her mini me, and wanted to be a nurse after, following in her footsteps and seeing what she did. She's always been a NICU nurse for premature babies. And so she had a huge passion for that. And she's one of the most intelligent people I know. So
when you started college, it was with the idea of becoming a nurse.
Yep.
And where did you go to college?
So I initially went to Deming here in Des Moines, Ankeny, for my associate's degree, and also got a general studies degree at the same time. And then I went on to what used to be called Kaplan University. I'm not sure if it's still open anymore, here in Iowa, and got my bachelor's degree. And then I went to Creighton University in Omaha and got my doctorate for my nurse practitioner.
Oh, great. And what was your first job as a nurse?
I worked on a trauma ortho medical surgical floor, taking care of neurosurgical patients, trauma patients, and then I transitioned to working to ICU, CCU with adult patients.
Okay. And Rebekah, where are you from originally?
I grew up in Altoona, Iowa. Going to high school, I went to a private school, so I went to Grandview Christian School, and I would say kind of my desire to pursue a nursing career in high school. I think it was our economics class, and just talking about different potential job perspectives and knowing I had a passion for trying to help people. And I had a friend who was older than me who was a certified nursing assistant at a nursing home and really enjoyed it. So I started out at the very end of high school obtaining my CNA. Actually started working at Mercy Hospital as a CNA, and then got into nursing school at Mercy Hospital and was able to get into a scholarship program where they paid for my schooling as long as I worked at Mercy for so many years. So I attained my associate's degree first. I got married young and actually was pregnant right when I started nursing school. And then I worked, my first job was actually at the hospital on a unit that's no longer there, but we took care of patients from the cath lab after they had a cardiac stent, different vascular procedures, and kind of worked in the healthcare system as a nurse for 10 years before I went back to school, got my bachelor's degree, then my master's degree, and then my nurse practitioner at Chamberlain University.
And let's talk a bit about nurse practitioners. It's called ARNP, Advanced Registry Nurse Practitioner. It used to be uncommon. Now it is very common. What's the path from going from being a nurse to a nurse practitioner? And then what does that credentialing allow you to do? So maybe start with you, Rebekah.
Okay. So once you're a registered nurse, then to be going on to be a nurse practitioner, you have to have your master's degree in the field of nursing. And then from that point, there's a couple different pathways that you can take to obtain your nurse practitioner, whether it's acute care, critical care, family nurse practitioner, with which both Allison and I have, or psychiatric nurse practitioner. And so usually it's an additional 2 to 4 years of schooling. And then your last year, you do a practicum with a nurse practitioner or a physician for extra training before sitting for your boards.
And typically you would have worked as a nurse, and as you said, you would go on to get your master's, and most nurses would be working while they get these advanced degrees that are done oftentimes online or in evenings. So
Correct.
it's really
Yes.
common that you continue to work as a nurse as you continue your education. And your process was the same. You had mentioned that you also have another degree that isn't as common, a doctor of nursing. So you have a master's in nursing and then a doctor in nursing, but the nurse practitioner is different than that.
So with the doctorate, both of us can practice independently in the state of Iowa. With our licensing and everything, we are our own provider. But with the doctorate, I did do more clinical, I did more practicum. I had to do a dissertation project that I set up and collaborated with another clinic, and also carried that out and got results and metrics and everything from it. And so that was part of the doctorate. And then also more clinical hours spent with another provider in different locations. And I can either practice in the clinic, or I can also go and teach other nurse practitioners that are master's degree or bachelor's degree.
So a couple times we've used the word provider, and so now it's common to talk about providers. So instead of saying doctors and nurse practitioners, the word provider includes physicians, nurse practitioners. Do we include PAs as a provider? Sometimes we do. So a PA, which is a physician's assistant, can't in the state of Iowa practice independently. So they're always practicing in a setting with a physician overseeing them. But nurse practitioners in the state of Iowa can function exactly like a doctor in terms of practice, can set up a solo practice in a clinic. And so I know that, as you mentioned, there's nurse practitioners can work in various fields, and often can, after becoming a nurse practitioner, sort of get on the job training in whatever particular field is of interest to you. So Rebekah, I know that you had worked in a pain clinic as a nurse practitioner in a pain clinic before coming on to the palliative care service. And Allison, I think yours was family practice, and then have come on to the palliative care team.
Yep.
And all right, then is there credentialing or tests or boards that you take to demonstrate competency in these specialties?
Yes. Yep. You can either go through, it's the AANP or the ANCC, American Nurses Credentialing Center, or I forgot what the AANP stands for. Both of them are nationally certified boards that you take your boards through. You go and sit in for an exam, and it's an extensive 3-hour, 4-hour exam.
So we are talking about lifelong learning here.
Yes.
And then just as physicians and pretty much everyone in healthcare, nurses, physicians, CNAs, there's ongoing certifications and recertifications to demonstrate competency as we continue to evolve and learn new things over time. Let's talk a bit about palliative care. So what is palliative care, and what's the role of palliative care in cancer care?
So palliative care, I guess just to kind of give a background, obviously with any type of medicine, our goal is to help people. And just kind of looking at where palliative care comes from, for the word palliate comes from the Latin word, which means to kind of cloak or cover up, specifically looking at a symptom from an illness without actually curing it. And so that's where the word palliative medicine comes from. Oftentimes palliative care gets associated with hospice care, and that's because it did come out of hospice care, which was founded in the 1950s by a British physician who really was looking at helping patients who maybe felt they had been abandoned when they had maximized, optimized medical treatment, and maybe it wasn't slowing or curing that disease process, specifically for terminally ill patients like cancer patients. So they really focused on, let's change our focus from aggressively trying to treat the disease to aggressively trying to treat the symptoms, and focusing on quality of life. And from that, that's where palliative care really kind of spun off of that, as we found with the medical profession, this may be beneficial to our patients who don't have a terminal illness, and we can provide this type of supportive care. In the 1990s, the World Health Organization, they really recognized palliative care as a specific entity where we can provide specialized medicine care to patients who have a serious illness with the goal of improving quality of life, trying to alleviate their suffering for patients at any stage with a serious illness, no matter whether they're seeking curative treatment or not.
Right. So helping to manage symptoms, helping to relieve suffering, and really addressing the whole person. I mean, physical, psychosocial, emotional, philosophical, spiritual dimension of how do we provide comfort and improve quality of life. And anything else you'd like to add to that, Allison?
We also always bring the whole family into it. We very much welcome not just the patient, but the entire family as a whole, because we see the patient and their family all together. You know, if they don't have that support system, we help them to find some kind of support system or provide them with our service. And so we really encompass the person as a whole, not just that patient.
Yes, and the whole family. And so a little bit more about the distinction between palliative care and hospice, because there is, they came out of the same sort of desire to help patients along the way. And it's also confusing for a physician to get a board specialty training. It's both palliative care and hospice. So you come out certified as palliative care and hospice. And some of it becomes a little bit about how we do insurance and reimbursement in the United States. So to be eligible, for a patient to be eligible to be enrolled in hospice home care, a physician needs to say that the expected life expectancy is 6 months or less. And so that makes a patient eligible for hospice care. And there's certain additional services that Medicare, for example, and insurances will pay for. But you can provide those same sorts of services and comfort care to patients if they have longer than 6 months to live. And maybe they even have a cancer that is potentially curable, but are having lots of symptoms, either pain or nausea or psychosocial distress, where having someone focus on their symptoms may be good, even as the oncologist is focusing on killing cancer cells. Maybe tell us about studies that show how palliative care for patients that are getting cancer treatment. So, for example, the lung cancer study that showed that bringing palliative care on board from day one, even while patients were getting active anti-cancer treatment, provides additional benefits over cancer care by itself.
So with those studies, really it focused on, like you were talking about, patients who were still getting curative treatment or anti-cancer treatment, and having palliative care alongside that extra layer of support. And really the study showed most of those patients had improved quality of life. They actually found that many times their survival rate, or it actually prolonged their life, and it really reduced the cost of healthcare, because they had already kind of determined and had conversations about what to expect in the future. At what point would they say that I don't want to continue to go through this. The treatment's not working. And I do want to switch that focus to just focusing on keeping me comfortable and keeping them out of back and forth to the hospital when their symptoms are uncontrolled, because we're helping to manage them.
Yeah.
Mhm.
And that was sort of the trifecta you mentioned, the study, which was randomized stage 4 lung cancer patients. Half the patients got whatever anti-cancer treatment the medical oncologist wanted to do, and the other half got whatever anti-cancer treatment the medical oncologist wanted to do. But a palliative care expert was on the team from day one. And every patient had better quality of life. Surprisingly, the group with palliative care actually had longer survival and much less expense. So it was sort of that trifecta that we're always looking for. How can we improve quality of life, the lifespan, and also reduce cost in healthcare?
Mhm.
So really a seminal study showing the benefit of palliative care. One of my focuses is to try to bring palliative care specifically to every patient that has stage 4 cancer, and then to the appropriate stage 1, 2, and 3 patients that are having symptoms or psychosocial distress. We're having someone focused on them as a person, not on their cancer cells.
Mhm.
So it's been great to have you guys come into the cancer center and actually be able to see patients with us, those of us that are oncologists. So I'm not a palliative care doctor, although I would say every oncologist, does palliative care, but I'm not a board certified specific palliative care.
Mhm.
What would you say? And let's just say that also palliative care is not just for cancer patients.
Mhm.
So, what would be the types of patients that don't have cancer that you see as a palliative care provider?
So we see a lot of patients like with any kind of lung disease, so COPD, restrictive lung diseases. We also see like neurodegenerative disorders, so aftercare from strokes, any kind of rare neurodegenerative diseases, dementia patients. We see a lot of those, helping with coordination of care. Um, we also see any kind of liver, kidney problems, complications with diabetes. What else am I missing?
I would say heart failure patients is
Yep.
another big population that we see. And sometimes it can just be a patient who we use a terminology like failure to thrive. So in the past 3 to 6 months, there's been a decline in maybe their cognitive function, physical function. They're losing weight, not eating. And sometimes we don't always know the source or the cause. They're in and out of the hospital, or we may see that their caregiver is experiencing burnout just with all of the different medical visits, the care that they're providing to the patient at home.
And you mentioned coordination of care, and we're going to talk about the other team members, but I often think of you as palliative care providers, a bit of a doctor, social worker, minister, counselor, but that social work part in terms of coordination of care, because we're talking about patients that we know are not going to be getting back to their normal state of excellent health. And
Mhm.
we're all mortal, and having this understanding of what do we do and how do we bring on more appropriate services as needed when needed,
Mhm.
and being able to anticipate that.
Mhm.
um,
So we go through a lot with our patients. We always kind of warn them with our visits. This is going to be a long visit, but we talk about a lot.
mhm.
And so we even touch base on how you doing with transportation. Are you having difficulty with getting to your doctor's visits? How can we help you with that? Are you having a lot of falls? Are you going in and out of the hospital a lot? How can we help with that? How can we prevent that? Bringing in home health care, bringing in other services, bringing in, the community health worker to help us with some of those kind of resources. And then even looking at their insurance. what do you qualify for? If you don't qualify for extra medical equipment in the home, how can we help you? Looking into other resources such as Easter seals or other, places that can contribute and can help them, especially with people who don't have the assets or the financial resources to get them the support. So it's very much thinking outside the box, as is all medicine. But, I feel like palliative care is just that plus more, because we do have a lot of patients who have such complex situations and everything where it's not just, okay, well, a lot of times we run into haven't been making the doctor's appointments. Okay, why? How can we help you with this? Or haven't been wanting to do treatment. Okay, why? Also, how can we help to support you through this? Is it something spiritual, physical, emotional, or do they just not have the resources and support for it? So we also always address that in all of our visits as well.
And as you mentioned, it's not a 15-minute appointment where you just write a prescription for another pill. It's a much more holistic, looking at all dimensions: the physical, psychosocial, emotional, financial, spiritual, and philosophical. I would say back to someone with stage 4 cancer, and stage 4 cancer in general, not every stage 4. Some types of lymphomas and leukemias could be stage 4 and still be curable. But for the most part, when we're talking about a stage 4 cancer, we're talking about a cancer that is treatable but not curable. And philosophically, what does that mean? How do I, as a human being, understand that even if this treatment works for a while, it's not going to cure the cancer? And at what point? So if you have a potentially curable cancer and you say, okay, this is going to be 6 months of treatment and it is going to just knock the snot out of you and cause lots of side effects, you say, okay, bring it on, because what I might get out of this is being cured of the cancer. But when you tell somebody who has incurable cancer that the treatment is going to make you feel even worse and it's not going to cure your cancer, that's not a good bargain to engage in. So it's really talking about goals and expectations, right? So maybe talk a little bit more, Rebekah, goals and expectations, and how a conversation, and let's talk again about cancer patients that, even with incurable cancer, with nowadays hormone therapy for prostate cancer and hormone therapy for breast cancer and immunotherapy for various cancers, patients may live 10 years with treatable but not curable cancer. How do you engage in that conversation about goals and expectations?
Yes. And part of that, like Allison was talking about, we have the time with our patients, an hour, 2 hours to spend the time with them and really kind of dive deeper and dig in. So many times I like to start out with, it's building a trusting relationship, getting to know them on a more personal level, and remembering that many of them have families, have jobs, have other interests, hobbies, and seeing them, like you talked about, more holistically and not just as their disease. And many times I'll start out and find out, what is important to you? What does quality of life look like? So asking them, what does a good day look like to you? What is important to you? And then trying to figure out how can we change things to provide more good days for you. And then matching that to align with what our treatment is that we're providing to them. And that can many times help them reach a goal about what's important to them. Are they more concerned about balancing quality of life versus longevity, somewhere in the middle, and then making sure that we're giving them all the information they need about what's going on with them with their cancer, what their treatment options are, and then helping them kind of delineate to make a choice, make a decision. As you always say, how do they find joy or meaning in their life? And then sometimes digging in deeper too, if they have made a decision, why did they make that decision?
Mhm.
Because sometimes it's because it's what their family wants or what they think their doctor wants
Mhm.
and not what they really want. Maybe they don't have all the information that they need, or maybe they're making it out of fear or anxiety of the unknown, or potentially realizing your mortality. And at some point, we all are going to die. So those are just a few of the aspects that
Mhm.
we kind of dig into with that conversation to help guide them with
And you
decision
mentioned
making.
that one of the conversation starters might be, what does a good day look like for you? As you mentioned, one of my conversation starters is, what has brought you the most joy since we last met? Because we all know people who want to live forever but don't have a clue what they would do today to bring joy to their life. So I do think it's a necessary part of being a human being to figure out what does bring joy to your life. Allison, what are some other maybe conversation starters, or as you engage in someone in a conversation to learn about goals and expectations, and other ways that you begin conversations like that?
So a lot of times developing that trusting rapport with patients, going in knowing their history, being very detailed, very thorough. When you go in with that patient and you say, I see that, you went here, you see this, patients almost sometimes act surprised of, I can't
Right.
believe you know all this about
Because
me.
they're used to somebody walking into the room say, so why are you here?
Yeah.
Knowing nothing about their history and sort of trying to wing it, and
Yeah.
having the ability to know what the patient's already been through.
Yes.
Can-
Also, and like you said, that helps to guide your conversation as well. If it's a cancer patient who has been through every kind of treatment line and had symptoms with every single thing, I like to touch on that first of, how are you feeling today? What does today look like for you? Is this a good day for you, or is this a bad day? And then kind of bringing that reality to them of, is this what your life has always looked like? And is this what you always want it to look like? And how can we support you with whichever you choose? And I also bring it to the forefront of all patients of, this isn't my decision. This isn't your family's decision. This isn't anybody else's decision. This is yours. And I'm here to support you through that and guide you through that. So you need to let me know what what your vision is of your life. Are you trying to make it to that grandkid's wedding? Are you trying to see your first grandbaby be born? And what does it take to get you to that point? Some people I have had tell me, I want to see that first grandbaby be born. I don't care what it takes to get there. Okay. That's your wishes, and that's how we can get you there. And some people just say, no, I just kind of want to travel some more. I want to see the ocean, and talking with them about, okay, is that a realistic expectation? Is that a safe option for you? Yes, you may want to see the ocean, but you can't, get out of bed for more than 10 minutes, so how else can we, help you to find, again, like you say, that joy, that satisfaction of seeing the ocean,
Yeah.
again, thinking outside the box.
And so I have one patient who has incurable cancer, treatable, incurable, and is like 75, and the goal is, I want to live to be 100 as the goal. Now that's a lofty goal that probably not realistic, and a slight tongue in cheek with that response, but that's always the response. And so you try to flesh it out. So I think I'm hearing you say you want to live as long as possible. And fortunately, this particular patient is on a treatment that isn't particularly difficult, and so not having a lot. But then, when it comes to, would you rather live to be 100 bedridden, or 90 playing pickleball? The decisions usually aren't that clear cut, but philosophically there is a difference. When patients get referred to you, do you have patients that are skeptical from day one, like they think, okay, this is hospice and this about getting ready to die.
Mhm. And we have a lot of, it's more common than not that we hear
Mhm.
that response. And even when we call the patient to get them scheduled with us, it's no, I don't want to see you. I don't want to talk to you, because not only is it scary because they don't know what we do, and we try and talk through our services, upon scheduling appointments, but you still always have patients that just don't understand, and rightfully so, and so we do try and guide them through that. But we also have the patients that show up and they're like, okay, so when am I going to die? And so they approach it as, I'm here to die, and so
And you're going to tell me exactly when that's going to
Yeah.
be. 'Cause
exactly.
You're the expert. You tell
Yes.
me.
And so reassuring them that no, nobody knows when you're going to die, but we want to help you along this path, And we do have some patients that ask us, what is my prognosis? And other patients just say, no, I don't want to know that. So, just always having that insight on each patient, I feel like is very appreciated from the patients as
Yeah.
well.
And that you're right, the prognosis, like how long exactly, is just so impossible.
Mhm.
But I do think it's important philosophically for a patient to know whether they have a cancer that is curable or not curable. Yes, miracles happen, but I think sometimes patients are going through chemo after chemo with this thought that one of these is actually going to cure them, where the doctors know, no, this is not chemotherapy to cure your cancer. This is palliative chemotherapy to try to just keep it under better control. So sometimes either patients don't hear that, or the doctors don't communicate it in a way that is clear that this is not a treatment that's going to make your cancer go away.
Mm-hmm. Did you have anything else to add
Yeah.
about scheduling appointments and stuff?
And yes, with the hospice, I would say probably 80% of my patients tell me that they're angry and upset that their provider referred them to our clinic, because they associate it with, they aren't wanting to tell me that I'm going to die or have that conversation with me. And so they've just kind of passed the buck and sent me to see you. And I think part of that stigma associated with palliative care is that many times patients do get referred closer towards the end of life instead of early on, because that's many times when they have the highest symptom burden going on. And so many times just reframing, educating them more about palliative care and thinking of us as an extra layer of support. And we really have their best interest in mind, no matter what decisions they choose as they're going through treatment or not treatment. It really can make a difference. And then by the end of our visits, I feel time and time again, both Allison and I have patients then that say at the end of the visit, now I wish that 2 years ago
I would have seen you.
I would have been
Yeah.
referred to your
Yeah.
clinic. Now I'm telling my family members, my friends about this palliative care service. And many times, yes, sometimes we're prescribing medications, ordering durable medical equipment, collaborating care, but sometimes it's just being present and listening actively to them and hearing them. And that's the support that we provide.
Unfortunately, in oncology clinics, I mean, with the shortage of doctors and the number of patients, the amount of time that patients get to spend with their oncologists is so small, such a short amount of time. So this luxury of being able to sit down with a provider and have an hour-long conversation with some in-depth conversation about the physical symptoms, but then also the time to really talk about philosophy and spirituality and goals and expectations. What are some of the tools, and what are some of the important things that you cover with someone who is facing an incurable disease? So, I mean, for example, my financial advisor wants me to get my funeral all set up and everything. I don't have an incurable disease other than, life and being a human being, which is, in some ways a terminal disease. But how do you work into your visits and conversations, getting patients to talk about advanced directives, code status, planning for funerals, etc.? What are some of the tools you use, and how do you work that into your visits?
So I feel like it very much depends on the patient. Some patients you see first time and they are very clear that they don't want to talk about that. They would rather develop that rapport first, that trusting relationship. And then I do bring up to them, I usually say, I ask this of all of my patients. I'm not concerned about anything with you, but it is something that needs addressed as part of our service. And I just say, do you have a living will? Do you have any kind of advanced directives, any kind of power of attorney? And if you do not, would you like me to talk with you more about that? Or would you like information on that? And I just let that guide me of what they would like for support. And if they say absolutely not, I respect that. But at the same time, if they want more information, we do have documents. We have what's called a prepare document that walks them through everything from how they feel right now to death, funeral arrangements, burial, autopsy, if that would be any of their wishes, and also their power of attorney. And we walk them through that, and then that's a notary document. And we do have notaries on our team. What else do you?
Yeah. And so kind of going forward with that, so we recommend the Iowa Prepare document because it's kind of a nice tool rolled in one where you can choose your medical power of attorney, but then it also asks some of those questions we've been talking about. What's important to you? Are you more concerned about quality of life versus longevity? Trying to think about those thresholds when it comes to medical care and decisions of life-sustaining measures. What are you willing to put up with, to prolong your life? What would be intolerable to you? For example, not being able to talk to your family if you're in a coma, being in the hospital hooked up to machines, not being able to think clearly for yourself with, advanced dementia, not being able to live at home, having to go to a nursing home, not being able to losing your mobility, being bedbound. And then that kind of helps guide them specifically for planning for the future for end of life care. What would you like that to look like? So that documents planning for the future. So that's how I guide my patients, whether they have an incurable or a curable. It's a lot easier to plan for the future. And when you're not in a crisis mode and you don't have all these high emotions going on, and it really can be a benefit to whoever you've chosen to be your decision maker, so they don't have that burden or potentially the guilt of what would that person, my loved one, want me to decide or make that decision for them. Another form we use is called the Iowa Physician Order for Scope of Treatment. And that's more meant for your current health today in regards to life-sustaining measures. Would you want aggressive treatment if you stop breathing? If your heart would stop, such as CPR, ventilation, then it delves into if you still have a pulse, if you're still breathing, what medical interventions, if your health decline, full treatment, limited interventions, just comfort measures, and then also gets into artificial nutrition with a feeding tube. And then that just has to be signed by a medical provider. And then that can be used out of the hospital. If something happens to you at home, EMS is trained to look for this form. You keep it on your refrigerator, and then that way your wishes are known to everybody.
And one of the advantages of that form is it's recognized by everyone. So before this, it was like every single institution and clinic had their own form, and you had to fill it out, and you couldn't take a form from somewhere else. And so this form, which is a recognizable color and very recognizable, can go with the patient, whether they go from home to the hospital or home to the nursing home or nursing home to the emergency room. This form goes with them and helps to provide that. And so you don't have to go through this critical conversation that could take an hour every time you go from one setting to another. Talk a little bit about some of your other teammates in the palliative care team. So besides the providers, who else do you have, and what type of credentialing and expertise does the rest of your team have?
So with palliative care, it is very much team sport.
sport.
Yes. And many times, in addition to having medical providers, we have nurse navigators, we have social workers, and we have chaplains. We are actually thrilled because we are in the process where we just hired a nurse navigator who has great palliative care experience, and they really can help with the coordination of care, even having some of those conversations about what's important, goals of care, advanced care planning. Our social worker, as Allison already highlighted on, we really use them to help with community resources, but also from a counseling aspect. And they're just a great addition to our team of helping patients who maybe have anxiety, depression, fears of the unknown, and maybe are not willing, or there's a stigma with going and seeing a psychiatrist, somebody outside of the palliative care team, and they're willing to talk and open
even
up.
the wait that you might have to see a psychiatrist. So to be able to have
Mhm.
counseling that's dealing with more of these existential issues
Mhm.
of anticipatory grief and depression and anxiety surrounded with just the life experience, as opposed to a organic psychiatric
Mhm.
disorder. One of the things that we are able to do at the Cancer Center, the Richard Deming Cancer Center, is to also bring on other supportive comfort services like massage and osteopathic manipulation and acupuncture and chiropractic care, and those sort of hands-on services that can help enhance quality of life. So they sort of get a one-stop shop of being able to see an oncologist and a palliative care provider, and also the wraparound services. Also, you have a chaplain, so addressing the spiritual needs.
Mhm.
It's interesting in talking to patients about their spiritual needs. Not everybody wants to go there, and it probably takes a while. And so, here in Iowa, although we are becoming more diverse and do have a increasing number of Muslim, and we have a population of Jewish patients, but being Iowa in the Midwest, the overwhelming majority of the patients that I see are Christians, and although the Christian theology would suggest that we're going to be just fine when we die, and that perhaps we're going to be even better off, I don't find most of my patients who will check the box that they're Christian take a lot of comfort in this theology that things are going to be great and there's nothing to be afraid of.
Mhm.
And occasionally you'll get patients who are clearly spiritually disturbed by how could a all-knowing and loving God allow something like this to happen. So you have a chaplain on your team.
Mhm.
At what point do you bring the chaplain on? Does the chaplain meet with everyone, or only those that you perceive are having issues related to spirituality, or those who ask to see the chaplain?
So I would say yes. Part of our assessment is evaluating for spiritual distress. And just like you mentioned, if the patient is discussing with us that, why is this happening to me? They're struggling to find meaning or purpose in their life. Even some of them have mentioned to us too, they're hesitant to change the path that they're going down with maybe transitioning to hospice care, because there may have been things that they've done in their life before, or they feel like they need forgiveness or reconciliation, maybe with other family members. So I would say those are a few of the things that will kind of clue us into getting the chaplain on board. Even just the fear of dying and the unknown, what's going to happen to me after this life. Some patients, again, aren't always open to meeting with a chaplain. So sometimes we do start with our social worker, Wendy, and then she can bring on board Jake, our chaplain, and really add him to the team. We offer it to all of our patients. And I feel like typically after they've seen us a couple times and they build that rapport with us, usually they're more willing then to meet our other team members and get them on board too.
Some people think that working in a cancer center is depressing, and some people think that working with patients living with incurable cancer must just be all doom and gloom. But I would have to say some of the most joyful encounters I have are working with patients that are living with incurable cancer and helping them on their journey and helping them find joy, because it's really about, okay, you know, how can we get more joy into your life? And let's talk about that.
Mm-hmm. And definitely with those kind of patients as well, they sometimes express that, you know, the stress of their cancer and everything is overcome them, but helping them to find the joy in everything, almost it's almost like a full circle of, you know, when, just like why we went into the medical field, of when you help somebody, you also, you know, get that happiness from that, of you are helping somebody. And, you know, when I've had plenty of patients who I've seen where they're like, you know, just talking to you makes my day, you know, and just having that reassurance that somebody's still there, somebody's listening, you know, you have to have the mindset that you are still helping people, even though, you know, they do pass, and, you know, but you helped provide them with that good quality of life and the life that they did have.
And the therapeutic benefit of just being present.
Mm-hmm.
And as we said, unfortunately, the way that the models of clinics are set up, they don't get to spend a lot of time with their cancer doctor, you know, having these conversations. Mm-hmm. So let's open it up to questions. We've got a live studio audience, and we also have folks that are watching us live streaming. If you're watching us live streaming, you can just put your question into the comments section, and we'll be looking for those. And we've got a microphone here, and we'll start with you, Angelina.
This is on, right? The microphone? George?
Yeah. Did you get to push the button?
Oh, okay. It was on.
There you go.
Okay. Yeah, I do have a question. It's good that this is being brought up, because my experience with my first nurse practitioner was, like I mentioned before the podcast, that I felt the lump myself. And when I asked for my particular doctor or any doctor, they said, well, all we have is a nurse practitioner kind of a tone. And I said, well, yeah, I think they're very much valid. I need to have this clarified. And she did. And she got the ball rolling. And it was on a Friday afternoon, and she called and bugged them on Monday to get the mammogram going. And they put me on priority. And I was like, wow, that's good. So I do give you guys a lot of credit. But it's interesting with that tone. I'm sure that a lot of people are not understanding what a nurse practitioner does. Because for the Mission Cancer, I do see one, and she goes thoroughly through all the tests and explaining where it's hard for the regular doctor, because, you know, it's kind of what Dr. Deming says. There's a shortage there. And I do appreciate nurse practitioners, because they are knowledgeable. And the nurse navigator explained everything when they found it, spread to my lymph node. And I was like, oh, you know, so I do appreciate that. But do you find some opposition because people don't have that clarity or understanding that you guys are actually the bridge between the doctor? You're not replacing, but you are kind of that more communication, I feel. Mm-hmm. Do you find any opposition of people questioning whether they should be seeing you and only a doctor?
Yes, I would say many times, like you brought up, that there is a lot of confusion. What's the difference between you know, a nurse and a nurse practitioner? Yes, we still are nurses at our core, but we do have that additional training. And like you said, many patients, once we do meet with them, they express many times, like, we want to keep seeing you because you spend the time with us. You're very thorough. You look through all of my records. You'll answer my questions, kind of try to bring it down to a level that's easy to understand and, work cohesively to help communicate with their providers. If they're struggling, that they don't feel like they're being heard, things are not moving quickly, which unfortunately happens a lot with the healthcare system, helping to make that happen. I can think of even recently, I had a patient that came to me that has end-stage renal disease and is on dialysis. I went to go get her to bring her back to the room, and the first thing she said to me was, "You are a nurse practitioner. I want a physician, and you look like you're 10 years old. So I don't know that I want to talk to you today." And her son came with her, and he was just kind of like, "Oh, what do we do?" So it took me a little bit of time to kind of break away those barriers. And again, by the end of the visit, she said, "Okay, I guess I'll continue to see a nurse practitioner.
Oh, good.
Maybe you do know what you're doing."
Other questions? Judy.
I have two questions. One has to do with family members or loved ones. When a family member becomes so upset that they're not doing any good to the patient, or it could be that they're interfering with the medical care, do you get involved in that, and how do you help that situation?
So I think many times, yes, with families, that is sometimes the main reason why we have patients referred to our clinic, because we can have a family meeting and sit down with all those key members to really talk about and bring the focus back to the patient and their values and preferences, and not the other individuals that, are important and part of their family, but bring the focus back to the patient. And sometimes it's really trying to work together to come to a consensus as a team. For example, we see some patients who, for whatever reason, have had to go to the court to have a guardian to help make decisions for them. And I had one recently where there was 3 co-guardians that were siblings, but one lived in Colorado, lived somewhere close by, somewhere not. And so it was really me questioning and finding out, when is the last time that you've, been to see your brother? What do you know is going on with their health? Trying to find out that maybe the reason you're pushing for this decision is so you don't feel guilty, or a burden.
Take a break, that the family member step aside for a while, even though the patient may not want that.
Yes.
So I've had a few patients where family members have had outbursts, and sometimes it's just bringing that family member into the hallway and expressing to them, "I know you're scared.
Right.
I know you're upset about this." And a lot of times I really find that that's where it does stem from, is they're not mad at me. They're not mad at the patient.
Right.
They're mad at the disease, and they're mad at what's happening. And they're mad that they have no control over this, just like the patient. And a lot of people don't know how to express that. And so just bringing that to the forefront of, I know you're upset. I know you're scared, but we need to kind of set that aside and dig into this of, let's find out what they want. And, 99% of the time when I bring that up, and I am very transparent and blunt about that, of, I know you're scared, they kind of look at me like, yeah, that is.
Yeah. And I would say, just to add to that in the palliative care setting with the team, we can also provide services and care and counseling to the family members. So we actually have a counselor who counsels family members. No charge. You don't have to wait a week. So that's not a type of service that most doctors' offices would be able to, on the spot, provide counseling to the family members. So we believe that by serving the family members, we're also better serving the patient, who's, technically the client that we have. And you had another question, Judy?
I did. sometimes, you probably get questions asked of you. This is kind of hard to discuss, but sometimes a patient just doesn't want to live anymore. And maybe their family members are even supportive of that desire. And of course, by law in Iowa, that's not permissible for a doctor or a professional to administer a life-ending medication. How do you handle that? Do you sometimes recommend, how do you handle it?
So how do you handle that when a patient expresses that they want help in bringing death sooner?
So with that, like you said, obviously in Iowa, there's laws against that. So again, I think it gets back to why is the patient feeling this way, that they don't want to live anymore? And kind of going back to, is it because they have poor quality of life? What can we do to improve that? Do they have uncontrolled anxiety or depression that's bringing about why they're saying that? And then we don't want them to make any big medical decisions if obviously,
They're not in their right mind.
yes, they're very depressed. So many times it is getting that counselor involved in talking with the patient or getting spiritual support with our chaplain involved. And sometimes it is where we get an ethical committee involved too, depending on what the situation may be of that individual not wanting to live any longer.
Great. Thanks. Other questions? There we go. Kevin.
So what do you do when you decide that person has a valid point, and
That's
this is what they want to do? Do you provide any hint at all what path they could go down to get to where they want to go?
that's when we start bringing up the hospice conversation, and we bring in the specialist from hospice, and we say, if this is your goal, that you no longer have a good quality of life, then let's focus on that quality of life at this point. That doesn't mean that we're going to help you end your life. That doesn't mean that it's going to expedite it or anything, but see if we can provide you more comfort in these last moments of your life.
Steve.
First of all, I have a great amount of respect for what you young women do. I didn't realize it was so intense in regards to the things that you have to go through. It just sounds like you've just got answers, and I don't mean this derogatorily, answers for about everything, because I'm just amazed at listening to all the things that you can do and help the patient have a better life, either in process of dying or the process of living.
Yeah. Yes, you're very perceptive, Steve. I've never met a palliative care specialist who doesn't have an extra amount of compassion. And I think that this work that Allison and Rebekah do is really in a very sacred space, and it does involve a desire to just help people. It's not so much about how to kill cancer cells or how to treat a disease. It's how to care for patients and families. So you're very perceptive. And I think that's a good place to wrap it up because we are out of time. So Allison Roth and Rebekah Rogers, both palliative care providers at MercyOne Palliative Care. And thank you so much for being with us.
Thank you.
Yes, thank you for having us.
If you know anyone that would benefit by listening or watching this program, it's going to be available tomorrow on demand on the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. And I hope you'll join us again next week. Thanks, everyone.